Thank you, everyone, and welcome to this RBMO live session on I3. My name is Mina Alikani, and I have the pleasure of co-hosting this session with Professor Juan García-Velasco, a co-editor-in-chief of Reproductive BioMedicine Online. Before I introduce Juan, who, by the way, needs no introduction, I'd like to say a few words about the journal. RBMO is, at least in my opinion and in the opinion of many, one of the most progressive and forward-looking journals in our field, which is really a character that was first instilled by Bob Edwards, who founded the journal. This is reflected in the type of papers that we publish and promote through sessions like this. We make significant efforts to help our authors improve and refine their work, and we showcase and recognize them in many different ways. Editor's choice papers, hot topic papers, a monthly newsletter, RBMO Insights that presents an in-depth look at articles in the talking points section, and of course, these RBMO live webinars on I3 all promote our authors and their work. And then a major recognition comes each year with our Robert G. Edwards Prize Paper Award, and we're very pleased to feature the winners of this year's award in this session. Now, a very brief introduction for my co-host, Professor Juan García-Velasco, although, as I said, he needs no introduction. His full bio is available on the I3 website if you are interested in reading more. Juan is the Medical Director of EVRMA, Chief Scientific Officer of EVRMA Global, Professor of Obstetrics and Gynecology at Madrid University, and a co-editor-in-chief of RBMO. It's a pleasure to co-host this session with you, Juan. And
thank you so much,
to you.
Mina. It's a true pleasure to be here with you today in this very interesting session. And I know all of you know Mina. She's extremely well known all over the world. Just as a brief introduction, Mina, as you know, is a board certified high complexity lab director in assisted human reproduction. She has many years of experience in the field and consults on several IVF technological companies where she's an expert. She's an editor of RBMO Online, and since 2022, she has served also as the president of Alpha, Scientists in Reproductive Medicine Society. So without further ado, I'd like to introduce our first speaker, and it's my pleasure to introduce Professor Sandro Esteves. He's the lead author of our Robert Edwards Prize winning paper. Dr. Sandro Esteves is a leading reproductive urologist specializing in male infertility and its intersection with ART. He's the founder and medical director of APHRODITE, a pioneering fertility center in Campinas, Brazil, and holds academic positions at the University of Campinas, Unicamp, and also in Denmark at Aarhus University. With over 25 years of clinical and research experience, Dr. Esteves is known for his work on sperm DNA fragmentation, semen analysis, and testicular dysfunction. He is the lead author of the APHRODITE criteria, a system guiding personalized hormonal treatment for men with fertility challenges. Dr. Esteves has published more than 350 scientific papers, is among the top 1% of global researchers, and is a founding member of the Poseidon Group, which developed new criteria for low prognosis ART patients. He serves on editorial boards for top journals in reproductive medicine and urology, and plays an active role in shaping global fertility guidelines through his leadership roles with the Brazilian Society of Human Reproduction and the WHO. Professor Sandro Esteves will present us the APHRODITE criteria addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. Sandro, floor is yours.
So thank you very much, Juan, for this very kind introduction. Also, many thanks to RBMO, its editors, for this invitation. I'm absolutely delighted to be here with all of you today to discuss male infertility. And from my side, I will provide you with a summary of our paper on the APHRODITE criteria for male infertility management. So here, my general disclosures. So this is our paper in which we propose a new classification system, what we call APHRODITE criteria, to identify infertile men who can benefit from hormonal therapy. So APHRODITE is an acronym for addressing male patients with hypogonadism and or infertility owing to altered idiopathic testicular function. So in brief, this system was developed through a collaboration of experts from 6 countries, as you can see in this slide. We had Peter Humayden and Niels Johansen from Denmark, Alan Pacey and Chris Barrett from the UK, Professor Lynn Antonio from Belgium, Herman Berri from Germany, and from Italy, Filippo Baldi, Carlo Alvidi, Manuela Simoni, and Daniele Sen. These are all, figures, important figures in the field of male infertility and reproductive medicine as a whole. So we aim to address a persistent challenge, which is the limited progress in the clinical management of men with reduced fertility and reduced spermatogenesis, particularly of idiopathic origin, because this is a stagnant scenario, which frustrates both clinicians and patients. So we as a group believe that the new APHRODITE criteria can provide urgently needed system to identify and characterize infertility in men seeking paternity and who are also potential candidates for hormonal treatment, particularly using gonadotropins. So it's important to say that these criteria are not applicable to men already diagnosed with infertility due to conditions like, for example, varicocele, infection, obstruction, because these patients wouldn't typically benefit from hormonal therapy. So the focus on hormonal therapy is particularly relevant for men with idiopathic infertility due to the essential role of reproductive hormones, FSH, LH, and testosterone for normal spermatogenesis. So it's common knowledge that deficits in the production or action of FSH and LH result in reduced spermatogenesis. Let's take hypogonadism, for example, which is characterized by low gonadal function, which is so common in males with infertility. So if we take, for example, the Leydig cells, these cells don't produce enough testosterone in men with hypogonadism, even when the LH levels are normal when we measure in the peripheric blood. So adequate levels of intratesticular testosterone in combination with FSH are essential for sperm development and maturation. But in men with hypogonadism, these levels are abnormal, resulting in reduced spermatogenesis. So hypogonadism has many possible causes, but in a large proportion of cases, we can't pinpoint a clear cause, in which case we call it idiopathic hypogonadism. So the name Aphrodite comes from the ancient Greek mythology. Aphrodite was the goddess of fertility, male sexuality, and procreation. So she was considered the counterpart of Poseidon, a god believed to influence female fertility. Interestingly, Poseidon has also made his way into modern medical terminology. A few years ago, a group that I participated, several of which also participate in the APHRODITE criteria, developed the Poseidon criteria, an acronym for a classification system designed for low prognosis women undergoing ART. So now in the world of infertility, Aphrodite and Poseidon serve as counterparts, Poseidon for female infertility and Aphrodite for male infertility. So the APHRODITE criteria have 2 key objectives. First, enhancing semen quality and or quantity for patients aiming for natural conception. And secondly, enhancing semen quantity and or quality to help make ART treatment more successful. So the classification of male infertility using the APHRODITE is based on clinical patient description, which is obtained from an andrological assessment, including medical history and physical examination, as well as routine laboratory tests, particularly a basic semen analysis, FSH levels, and total testosterone levels. So for semen analysis, the WHO framework and reference ranges are applied, and patients are classified as having normal or altered semen analysis parameters, including azoospermia. So FSH levels are categorized as low, normal, or high, based on typical reference ranges, which may vary depending on the platform used for FSH measurement. But for most of us, the normal range is from 1.5 to 12 international units per liter. Now, when it comes to testosterone levels, patients are categorized as having either normal or reduced levels, relying on cutoff values outlined in most relevant guidelines. One particularly critical threshold is set at 350 nanograms per deciliter, which is equivalent to 12 nanomoles per liter, which serves as the most consensual thresholds for identifying patients with what we call biochemical hypogonadism. So eligible patients are classified into one of 5 groups based on the andrological assessment and lab parameters, and recommendations for unified clinical management using gonadotropin therapy are provided. So let's have a look into more detail on each group. So in group 1, we are looking at patients with congenital or acquired hypogonadotropic hypogonadism. These patients have a severe hormonal disorder caused by deficient gonadotropin production or action, which prevents their testicles from producing enough sperm and testosterone. They typically exhibit very low FSH and LH levels, hypogonadism, and azoospermia. But here is the silver lining. Gonadotropin replacement therapy using HCG alone or combined with FSH can work wonders for most individuals in APHRODITE group 1, and it can revive spermatogenesis. So with the right treatment, these patients stand a solid chance of becoming fathers. Now moving on to APHRODITE group 2, here we are primarily looking at a category of patients with idiopathic oligozoospermia and also a specific case of normogonadotropic, eugonadal, idiopathic, non-obstructive azoospermia. Just to refresh, patients with idiopathic male infertility have abnormal semen analysis, but lack a history of diseases affecting fertility. And additionally, their physical examination and lab results are mostly unremarkable. These patients are believed to have functional hypogonadism caused by reduced gonadotropin action, even though the FSH, LH serum levels seem normal. So APHRODITE group 3 is a variation of group 2. Patients showcase abnormal semen analysis parameters and normal FSH levels, just like group 2. The difference is that this group exhibits reduced testosterone levels, indicating biochemical hypogonadism. So we have research suggesting that FSH therapy can enhance semen parameters and boost pregnancy rates in men with idiopathic oligozoospermia, like those patients fitting APHRODITE groups 2 and 3. So while in group 2, clinicians can consider FSH monotherapy to improve sperm concentration and pregnancy rates, co-administration of HCG and FSH may offer additional benefit in group 3 because these patients have low serum testosterone. Now, moving on to APHRODITE group 4, this category primarily includes patients with non-obstructive azoospermia, displaying elevated FSH levels and reduced or compensated testosterone levels, which indicates hypergonadotropic hypogonadism. These patients have very low testicular reserve, making them the most difficult patients to treat, like we have, for example, Poseidon group 4 patients. So in fact, these patients, the main treatment is sperm extraction surgery. However, sperm retrieval outcomes remain suboptimal in patients with non-obstructive azoospermia in general. So one key challenge is that these patients often have varying degrees of Leydig cell insufficiency, which coexists with spermatogenic failure. In this scenario, the question is, could hormonal stimulation improve sperm retrieval rates? Well, there's data suggesting that for men with non-obstructive azoospermia, hormonal stimulation before the sperm retrieval may help. However, there is significant patient heterogeneity across, several studies. These studies are mostly observational, making it difficult to draw firm conclusions. This is where we believe precise patient stratification like the APHRODITE system becomes crucial because it may help identify who is likely to benefit from hormonal therapy. One thing that is important to note is that there is considerable variation in the hormonal profiles of patients with non-obstructive azoospermia. And according to the APHRODITE criteria, these patients can fall into groups 2, 3, and 4, which highlights just how crucial hormonal assessment is when considering hormonal therapy for these patients. So obviously, a one-size-fits-all approach won't work here. So understanding where a patient fits hormonally is very important to determining whether hormonal stimulation might improve their chances of sperm retrieval. So our recent study, including over 700 patients with non-obstructive azoospermia, found that 8 out of every 10 patients with non-obstructive azoospermia had testosterone levels below 350 nanograms per deciliter, meaning they meet the criteria for biochemical hypogonadism. So according to the APHRODITE criteria, most of these patients fall into groups 3 and 4, and this suggests that a large proportion of patients with non-obstructive azoospermia could be potential candidates for hormonal therapy with the aim of boosting intratesticular testosterone production. So this matters because in our study, as well as in others, sperm retrieval rates were significantly lower in patients with low testosterone than those with normal levels. So what if we could change that by using hormonal therapy? We have looked into that. In another recent study, we explored the role of HCG in boosting testosterone production in men with non-obstructive azoospermia and biochemical hypogonadism. So in this study, we included over 600 patients, with about half of them receiving HCG therapy for about 4 to 5 months before the sperm retrieval, either alone, HCG either alone or in combination with FSH. So we found that pre-sperm retrieval hormonal therapy was the strongest predictor of success with microdissection testicular sperm extraction, which was the technique we used to harvest sperm from these patients with non-obstructive azoospermia. And in fact, sperm retrieval rates were significantly higher in patients who received hormonal treatment compared to those who did not. Then, when we split our cohort of hypogonadal non-obstructive azoospermic males according to the APHRODITE criteria, we found that group 3 patients were those who benefited the most from the hormonal therapy. So what does this tell us? For patients with low testosterone, but still normal FSH levels, boosting endogenous testosterone with HCG therapy may help stimulate spermatogenesis and improve their chance of sperm retrieval. So let me now wrap up with APHRODITE group 5. This group comprises patients with unexplained infertility. These patients present a unique challenge because semen analysis, hormonal levels, and physical examination are normal. Their partners' evaluations are also unremarkable, yet they remain infertile for reasons we don't fully understand. So here, the idea of employing FSH to stimulate spermatogenesis in this group of patients particularly is based on the fact that in primates, spermatogenesis doesn't run at its highest capacity, and extra FSH may be able to stimulate spermatogenesis beyond its baseline. Obviously, we need much more research to determine whether FSH stimulation is truly beneficial for men with unexplained infertility. But one thing we do know is that higher sperm counts are linked to a shorter time to natural conception. And very interestingly, the values associated with shortened time to conception are far above the lower normal limits as per the WHO semen analysis reference values, as you can see here in this slide. This is the 50th percentile according to the WHO. This is where we achieve the plateau according to this study, shortening time to conception. It's much higher than the threshold set by the WHO. So this provides a theoretical rationale for considering FSH therapy as a way to enhance spermatogenesis, potentially improving fertility outcomes in these patients. So in a nutshell, the APHRODITE criteria provides a clear, structured way to stratify patients, improving communication and guiding target treatments. And we hope that the adoption of the APHRODITE criteria will support more personalized care, facilitate research, and enable the comparison of outcomes across groups. And importantly, this system also opens the doors to future discoveries, whether it's new therapies or a deeper understanding of male infertility. We are very excited about the future and the possibilities this approach brings for advancing male infertility treatment and research. And we are very proud of the impact this work is already making and honored that it was recognized with the 2024 Robert Edwards Prize Paper Award. So on behalf of our authors, I want to thank the editors of RBMO for the award and the opportunity to present the APHRODITE criteria here today. Thank you very much.
Thank you so much, Sandro, for this very clear explanation, and congratulations for the award. I think it's well deserved because I fully agree with you. I'm a gynecologist, and as a clinician, sometimes we just jump over the male factor with ICSI or whatever is needed without paying much attention. We will have plenty of time after the second lecture, but I would like just to clarify this classification, the APHRODITE, is mainly to do a better diagnosis of men with idiopathic infertility that may benefit from hormonal treatment. Is that correct?
We are trying to change the mindset, Juan, because what you guys are doing in female infertility, and especially ovarian stimulation, for so long, is actually boosting the potential of the ovaries to bring eggs without actually paying a lot of attention in etiology. Obviously, etiology is important. You have a PCOS patient, you tailor your hormonal stimulation, but what you are ultimately willing to achieve is enough and healthy eggs to make IVF successful. So in male infertility, we have been historically trying to diagnose, but the treatment is not actually materializing in something that could improve, the outcome for the patient. So we believe, obviously, diagnosis is important because if I make an andrological evaluation, I will rule out some patients from APHRODITE because these patients have very well recognized etiology. For example, infection, obstruction, varicocele. But for idiopathic, we want to, let's say, mirror what you guys are doing for the ovarian stimulation. Let's try to kind of recover or stimulate the full potential of these patients by hormonal stimulation to improve quality quantity that could provide better opportunity not only for natural conception but also to improve ART outcomes. So it's kind of also looking into the diagnosis but also trying to change the mindset of what has been historically done in male infertility treatment.
So it's like a change in the paradigm for sure. Excellent. Okay, so maybe we can move on, Mina, with the next speaker. Thank you, Sandro.
Thank you, Juan. Thank you.
We can't hear you, Mina. Sorry.
Apologies. Sorry about that. This is the perpetual issue of being on mute and talking to yourself. Sorry about that. Thank you very much, Juan. And so it's my pleasure to introduce the RGE Prize runner-up, a paper by Dale Goss and co-workers representing multiple academic institutions and a startup company in Australia with the title Evaluation of an Artificial Intelligence Facilitated Sperm Detection Tool in azoospermic samples for use in ICSI. Dale is an embryologist at IVF Australia in Sydney and a clinical and basic science researcher. He has a bachelor's degree in medical science with honors and a master's degree from Stellenbosch University in South Africa, as well as a Master of Clinical Embryology from Monash University in Melbourne. He's currently a PhD candidate at University of Technology, Sydney, School of Biomedical Engineering, researching the foundational causes of reproductive dysfunction. Dale is also part of Neogenics Biosciences, a medtech startup developing chip and AI-based solutions for IVF processes, particularly focusing on sperm isolation and computer vision-based detection. Gail, I'm sorry, Dale, we look forward to your talk. Thank you.
Right. Thank you very much, Mina, for that introduction. It's an absolute honor to be here with all of you today. And I just want to first say thank you to RBMO and the editors for the recognition of our paper. It's very great to see that we're getting this recognition. So I'll be speaking today about of course, our paper that's won this award, which covers a lot of preclinical work. And I'll give you some background into our clinical results thus far. So here are my disclosures. To give you some background, this won't be new to a lot of you, but around 10 to 15% of male factor infertility involves azoospermia, and around 60% of those are caused by impaired spermatogenesis. So this can be either congenital or acquired, and is characterized by being non-obstructive azoospermia. The main treatment approaches, of course, we all know this, extended sperm search of tissue or semen, followed by ICSI if we find sperm, and adjunct therapy. So these are often the only route to having biological children for these patients, and it places considerable physical and emotional strain on these patients. It's extremely invasive in the surgical aspect, and many of these patients don't have the option to access donors or sperm donors or to adopt children. So they consider this terminal infertility. So the time-intensive sperm searches are not only a strain on the patients, but also on the clinics and the laboratories to support these treatments. And I'll show you here quickly is a typical workflow for sperm retrieval surgically in azoospermic patients. So we begin with testicular surgery where a biopsy is taken, the tissue is processed, washed to concentrate the sample. The sample is then plated onto dishes for searching. And then the sperm search process can take up to 6 hours. We've heard people saying that they go overnight. So 12 hours, multiple staff performing these searches. If we're able to actually find sperm, then we inject the eggs with ICSI. Here's just the kind of a complex sample showing you what it really looks like going through the search process. It's really a needle in a haystack scenario. It's a very difficult process for the lab. As I mentioned, it takes hours of searching, which induces fatigue and of course then inaccuracy in the search process, which means missing sperm, which is catastrophic. The experience or the stamina of the operator affects our chances of actually finding sperm. So it's a very subjective and operator dependent process. The quality of the samples received from the surgeon and then the preparation process in the lab also influences the complexity of the search. And then the success rates of actually finding sperm, not even considering the downstream embryology outcomes, are around 30 to 60%, depending on the etiology of the azoospermia. So our objectives for this study were to address a clearly unmet clinical need to improve sperm identification in these non-obstructive azoospermia patients and cryptozoospermic semen samples. We felt we are obligated to find the sperm if it's there, even if it's a single sperm in an entire sample. I believe we owe it to the patients to give them that chance at their own biological children. So we wanted to develop and validate a machine learning model that can actually help us in the real-time sperm detection during this laborious sperm search process. And by doing that, we could improve the search efficiency and the consistency in these searches to support a better ICSI workflow and the outcomes of these treatments. So I'll briefly explain how we trained the AI model. We acquired excess testicular tissue samples and semen samples from consenting patients and donors. We then performed imaging to create hundreds of images, which then had thousands and thousands of sperm instances in those images. The images were then augmented to synthetically amplify the size of our data set with spectrum of contrast and blur and orientation. Those images that we then took and augmented formed our training data set. And we used YOLO V8 model architecture to create a model capable of training the images we took. So you'll recognize YOLO V8. It's an approach similar to what's used in self-driving cars and traffic monitoring, as you can see here. We used 85% of those images to train and teach the model to detect sperm, and then the remaining 15% were used then to validate for pre-testing to see if the model was performant and had sufficient recall and precision. So I'll go into those metrics later. And then once we were comfortable with the performance of the model, we were then moving on to our testing phase, which is in the paper. I just wanted to give you kind of the background on the challenges that we actually have to face when we're doing this training process. So training a model to do sperm identification. You can see here there's a picture of a fairly nice looking sperm or normal looking sperm. We have to create a model that can address the differences in what we would normally see in a real-time scenario in different types of microscopes as well. So we created an image pipeline which considers all these factors. So firstly, illumination conditions. So the brightness and the contrast spectrum that you would see in different scenarios might not look very different to the naked eye down the microscope, but at the pixel level, which the AI is using, it can have an exponential effect. Occlusion, we all know this one. If there are a lot of collateral cells and tissue, you might have occlusion of the entire sperm or half the sperm. We want the AI to still detect parts of a sperm in a field of view so that we're not missing sperm. Intraclass variation, of course, when you're using testicular tissue and the sperm that are coming out of the testicles, you get a high variation in sperm morphology. We also get it with semen, but we want it to be trained on the entire spectrum of what it would see in the real world. Deformation, of course, it goes kind of back to intraclass variation, but when you have deformation of the sperm structure, we still need the AI to be able to recognize that it is a sperm, even if there's a bent tail or a bent head and curled up tails. Cluttered or textured backgrounds, we wanted to give it kind of robustness for the spectrum of different complexities of collateral cells you would normally see in a sample. So very dirty cells that have a lot of red blood cells or white blood cells versus much cleaner cells. Semen versus tissue, we wanted to create a very broad spectrum of the data set. And then viewpoint variation. So if a sperm is, although we are searching at 2D down the microscope, if a sperm is orientated in a way that it doesn't exactly look like a sperm, we need to make sure that the AI will still detect it. So this is why we created this training data pipeline that we could actually make the model performant and robust. And these are just some examples of kind of the variation that we would see. And this pertains a lot to the color and other factors such as the brightness. So our first prototype after we'd done the training was ready for testing, and you can see the basic setup here. This is similar to what the clinic deployment setup would look like. So you have a monitor connected to the PC that has a graphics processing unit on it that can run the AI model. a 4K microscope camera connected to the microscope that provides the live feed, a sample dish on your ICSI microscope that you obviously are searching through. And our first prototype, as we had it, you can see here I'm panning through tissue samples. There is sperm here, so this is not likely the ones that we struggle with the most, but you can see the bounding boxes, the green ones around the sperm. We had in this case, we had a kind of spectrum of confidence. So closer to green is more confident, and closer to red is less confident that it's a sperm there. And you can see as I'm panning through, the AI is instantly detecting the sperm in the field of view. So to test the utility of the AI model, we had two testing scenarios. Firstly, what we had to do was to acquire excess tissue samples from consenting in-treatment patients as our formulated background. The first scenario was on still images, where we took the AI by itself versus an embryologist by themselves and compared metrics on searching. And then the other scenario was a simulated deployment, very similar to how it would be in the clinic, where the AI is assisting the embryologist like a co-pilot, and then that embryologist assisted by the AI is compared to an unassisted embryologist just doing manual searching down the eyepiece. So for the still images cohort, we assessed time per field of view or per image, and it took around 1,000th of the time for the AI to detect all the sperm in the field of view per image, compared to the embryologist. The recall, which basically means did you miss any? So the percentage of true sperm correctly detected. Recall reduces when you have false negatives or missed sperm, which are obviously very consequential and catastrophic. We don't want to be missing any sperm. So the results are good for the AI here, but obviously not for the embryologist. The AI missed significantly fewer sperm than the embryologist did. So we were finding more sperm with the AI than the embryologist. And precision, which is, it considers all the detections and if they are true. So the percentage of AI annotations that were correct, so true sperm. So with precision, it reduces when you have false positives. So we were actually expecting the precision to be lower in the AI than the embryologist, because we purposefully allow false positives so that if the AI encounters something it's not really seen before, we still get a detection there, so that there's less likelihood of it missing any sperm. So it was lower significantly in the AI group, but if we raise the precision too high, we may get a drop in the recall, which we don't want. So the preclinical, so the simulated deployment, this is the basic setup of how we did the dishes. So you can see the vertical strips are where we would put the sample, and those are droplets. You can ignore the circular droplets that normally where eggs would be put. So when we compared the time per droplet, we saw around a 40% reduction in time to search each droplet, using the assistance of the AI versus the unassisted embryologist. And then when we looked at the sperm found per droplet, we saw consistently we were getting a few more sperm in the group where the embryologist was assisted by the AI, but this wasn't significant when we did the statistics. And of course, we published this in our paper. We were very happy with how it was performing. We then went on to do more training, and we made the model more robust, and we began the next phase of our study, which I'll give you some preliminary data now. So you can see the panning on the right is a cryptospermic sample of semen, and this is our more recent model that we're using. The study that we're doing at the moment is a side-by-side clinical testing study at 3 sites in Australia. We have AI assistants in one scientist who's being assisted by the AI versus manual searching with at least one other embryologist. So a side-by-side comparison. So it's on consenting in treatment, poor prognosis azoospermic patients, where we're doing micro-TZ, the semen extended sperm searches, as well as frozen samples from these. Our primary outcome for this study is to see if there is a time-saving benefit of using the AI in clinical treatment. And the secondary outcomes are the number of sperm we find and then all the downstream embryology outcomes. So we're seeing per sperm found, we're seeing around a 70% reduction in time to find each sperm. And this is the cases where we've actually found sperm. And then we're seeing around a 40% reduction in time per dish. And our dishes are set up very similar to how I showed you in that simulated deployment. It gets quite interesting when we start looking at the number of sperm found as well. In the AI group, we're seeing around 113% increase in sperm found per patient with the use of the AI. And we finding around 50% increase in the number of sperm found per dish. So that 113% is kind of taking into account that we're doing more dishes in a shorter period of time with the AI, but we're also finding more sperm, which can infer that we are missing fewer sperm than what an embryologist would miss during these surgeries. So this doesn't really paint the whole picture, of course, this data, but I just wanted to give you a quick anecdote in the form of a case study we did last year, part of this study. We had a micro-TZ sperm search with using the AI, obviously side by side in the study, of in an AZFC patient. So the male was AZFCY deletion. He's 30 years old, and his partner was presumed fertile, also 30 years old. It was their first cycle, and they're considering a donor sperm, of course, as they've been advised by their doctor. And we had the micro-TZ surgery on the day of oocyte collection. We collected 25 oocytes. 24 of them were mature, and one of them was immature. We had 3 scientists searching the tissue for 3.5 hours, where we had 1 scientist using the AI who found 13 twitching sperm, and we had 2 unassisted scientists who found 2 twitching and 1 immotile sperm, which we actually never ended up using. We injected the 15 oocytes, and 9 were frozen, and we got 2 nice blastocysts from that AI cohort, and 1 was transferred, and we had a healthy baby born in January this year, which turned out very nicely for the patients. But this was a case of pure numbers. We were able to get more sperm, hence we were able to then inject more eggs, and we had a higher chance of getting embryos from this cohort. So some key outcomes and the future directions of this research. We believe the AI model has the potential to enhance the care for men with azoospermia by improving sperm identification in these very complex samples. So these men have a very hard time, and we feel the technology just hasn't caught up to address this plight. So we need a more effective and a quicker way to address these cases so that the labs can handle them. It detects sperm around 70% faster than an unassisted embryologist, and that then reduces the searching time as well as the working load on the lab. So Sperm Search AI, which is the product we've developed from this, is now a plug-and-play research use only application, and it's compatible with standard ICSI microscopes, and we provide cameras, and it's part of the workstation. So we've thus deployed in 10 clinics and 5 countries so far. We continue to refine the system and grow the training data set, and we want to improve the model's performance and adding additional features along the way. But I'll leave you with this one, which is that we think that basic science still has a very large role to play in the development of better IVF treatment in the current day, and I think we need to keep pushing to support that. So the team so far is obviously growing. I just want to thank everyone from the Neogenics Biosciences team who've worked very hard on this, and all of our clinical collaborators, specifically the Virtus network, IVF Australia, Melbourne IVF, and Queensland Fertility Group clinics, and all the doctors that have been very supportive thus far. Thank you very much for listening.
Thank you so much, Dale. This is fascinating and truly an area where we as embryologists need help, and the kind of help that you presented here. I have a lot of questions, but the first one I wanted to ask you is, does the AI take motility into consideration at all, or is it just morphology and in other words, the presence of sperm regardless of motility?
Yeah, at this stage, the co-pilot searching model that we have isn't grading or assessing the sperm in any other way than pure detection. We haven't put in motility tracking yet because we want it to, well, mostly because the sperm that we're looking for are not likely to be highly motile, and once they are highly motile, the the searching process is, you don't actually need, it's not as hard when to detect a swimming sperm than it is to detect an immotile sperm sitting on the corner. So at the current state of the AI is that we're not grading the motility or tracking the motility, but it will identify swimming sperm. So if you go into a field of view and there's a sperm swimming, as long as it's in focus, it'll detect that sperm. Yeah.
Right, right. So I was more thinking about test samples where we're looking for sperm, not with progressive motility, but at least
Yes,
twitching.
twitching. Yeah,
right?
yeah. So that's,
So
we're working on that at the moment.
We
Yeah,
have a
because you spend
preference
so
for-
much time staring at a sperm,
Yeah.
trying to figure out if it's twitching. Yeah. So yeah,
Exactly.
it's it's in our, we're actually busy with it at the moment in that, yeah, discerning between browning in motion and just actual tail beating, definitely a priority. So that'll be very helpful to have it. But at the moment, it's not included right now.
That would be an amazing addition because,
Yeah.
of course, everyone has a preference to inject at least twitching sperm because it has fluid viability, and we can't tell the difference between viable and non-viable sperm except for that twitching and motility. So I think that would be an amazing feature.
Agreed.
To add in the future. Juan, should we open the floor to Q&A and invite Sandro as well?
Yeah, I think let's bring Sandro and maybe we can start asking. There are plenty of questions from the audience.
Yes.
So let's wait for Sandro. Oh, here he is. Okay. Okay. So if I may, I will start with a question that is repeated several times. It is basically for you, Sandro. Is asking, how should clinicians apply the APHRODITE criteria? I mean, what are the key parameters of the APHRODITE criteria that may help us distinguish between treatable and non-treatable forms of idiopathic fertility? How can you guide clinicians in a practical way?
So thank you very much for this question. So it's important that we emphasize that the APHRODITE criteria are primarily for patients with idiopathic, male infertility. So we are not talking about other forms of male infertility. We are trying to find a way to better stratify these patients in which we can propose, therapy, particularly using gonadotropins. So basically, all patients are potentially eligible for treatment, idiopathic patients. The benefit of the classification is that different groups will have different prognosis. Because if we consider that from the beginning, and this is, I believe, what we should do in our clinics for every single male patient, is to have the andrological evaluation, which is done through the medical history, the physical examination. We will rule out some patients, of course, from APHRODITE, because we can say, well, this patient has a varicocele, and he could benefit from, a varicocele repair or an obstruction, etc. But for idiopathic patients, in which, by definition, are those patients that we could not identify the clear etiology, and this the andrological evaluation will guide us. And then what we add the semen analysis is part of our assessment for every single patient, the basic semen analysis, and then FSH levels and testosterone levels. These are the main, elements for you to make the stratification. Then you can kind of put your patient in different groups. And according to the group, we propose in APHRODITE. So I invite all of you to, go into the detail of the paper published in RBMO. There are many more than what I was explaining today. So we try to make therapeutic management individualized for different groups. So group one, just to give you an example, these are very good prognosis patients because these patients have hypogonadotropic hypogonadism. For these patients, we need to make replacement therapy But it differs. It's not FSH for everyone. Because if I have a patient, for example, with congenital hypo, this patient needs a combination from the start of FSH plus HCG to provide LH activity. So if the patient is adult onset hypo, for instance, pituitary surgery or anabolic steroids use, things like that, we can start directly with HCG alone, monotherapy. So just to give you some examples on how we can individualize therapy. And then if you go group by group, you see that also the therapeutic management will vary. So the parameters from the start were those that I said, and then the management will be individualized based on group by group.
Okay, thank you very much. If we can continue with you also, I think there are questions that are quite interesting as well regarding timing. I mean, for how long should we treat these men? And also, because we're talking about FSH co-treatment with maybe something else. There's a question here from Dr. Cunningham from New Jersey asking if Clomid might be beneficial for this testosterone stimulation in these APHRODITE criteria patients. Or Dr. Sahir from the Emirates, a similar question regarding letrozole. So would these two compounds be useful as co-treatments, and for how long should we use them?
So I think for the treatment duration, we need to think about the duration of the spermatogenic cycle, which is about 3 months. I mean, so every time we do anything for our male patients, we need to consider, respect that time frame. So even when we ask the patient to quit smoking, we will see the benefit in the, let's say, the next spermatogenic cycle. We need to wait for 75 to 90 days. So the treatment is the same. We need to give treatment for at least 3 months, but it depends on the group. For instance, the subcategory of patients with non-obstructive azoospermia that we, in our paper that I was presenting, we showed to benefit from hormonal stimulation, Juan, we gave on average 5 months, so almost 2 spermatogenic cycles, because the severity of the spermatogenic defect was much more pronounced. So I think we need still to collect much more data now, because these criteria were just launched. And obviously we need to, stimulate different groups to make research, both, with retrospective analysis of their databases and prospective trials for us to understand the best time frame for treatment. But from the theoretical standpoint, we need to keep at least the 1 spermatogenic cycle, that is about 3 months. So concerning the question of other drugs that could stimulate, intratesticular testosterone production and also boost your endogenous FSH and LH, like selective estrogen receptor modulators like clomiphene citrate, or aromatase inhibitors like letrozole. These molecules, they will engage in a mechanism completely different than the gonadotropins. That could be tried, of course. We have many trials historically in the urological field showing that, these drugs could improve sperm concentration, that could improve testosterone levels, although the impact on pregnancy rates are, less robust. But yes, this could be done. The only thing which is important to note is that we are moving to an area where genetics makes a very important, contribution to our understanding of female and male infertility. And in male patients, we have the polymorphisms also affecting the molecules like FSH, LH, and the receptors. So when we use drugs that engage the hypothalamus pituitary gland to release endogenous, FSH and LH, we are not overcoming the polymorphisms that could exist in, FSH and LH of certain patients. And we have some data indicating that these polymorphisms could be quite prevalent especially in patients with non-obstructive azoospermia, some studies showing up to 30%. And for idiopathic oligospermia, in up to 15%. So although these drugs could be explored, they will never overstimulate like gonadotropins, like we do for, the ovarian stimulation. This is the same concept. So we believe in the APHRODITE group that the primary, focus should be on gonadotropin therapy.
Okay, thank you.
I have a couple of questions for Dale. Were there any samples where you could not find any sperm, and the AI also confirmed that sperm could not be found?
Yes. So in the current clinical testing at the moment, we had obviously the confirmation of absence of sperm completely in the sample where we give up and we stop searching, where the AI is obviously confirming that. But we have had cases where we found sperm with the AI and not with manual searching in specific cases. Sometimes we'll find one or maybe a half a sperm or like something not usable without the AI, and then we found 3 or 4 with the AI. But it's all a function of time and when we can actually get the eggs inseminated. But I think, to answer your question, there's been, like, when there's no sperm, there's no sperm. It's not going to find anything that's not there, of course.
Right. So what is the role of the embryologist in the assisted arm? Just moving the slide or the dish?
Yeah. So how it's used is that we have quite a nice big monitor at eye level next to the microscope. So instead of doing the search down the eyepiece, the embryologist controls the stage and controls the fine focus knob. And then you basically just going into a field of view. You got your live camera feed on the monitor. And if there's anything that looks like a sperm or is a sperm, the AI will put a little box around it. If there isn't anything, you just go to the next field of view. So you're panning, making sure you're in focus, and then going to the next field of view. Keep going like that. So you're scanning, you don't have to scan, like an embryologist will sit down and look through the eyepiece and scan to make sure that they've looked at the entire field of view and there's no sperm there, and then they go to the next field of view. With the AI, it does that instantly. So you're only looking for the bounding boxes that are appearing, the little blue boxes.
Right. And then do they then have to pick up that sperm?
Yeah. So you have your needle, there ready to go, and you're just using the monitor instead of the eyepiece. And as soon as you find a sperm, you just pick it up and you use it. You put it in an isolation drop, and you can use it for inseminating later on. But the study itself is purely based on the search process, but it is in treatment patients that we're creating embryos, and it's in treatment patients. We're creating embryos and culturing them.
So, there are questions about efficiency. Have you demonstrated that it's more efficient in identifying sperm, especially in those very difficult to manage samples where, you scan 15 fields and you may not find a single sperm, and it's frustrating, and it'll go on and on.
Yeah, so the paper itself showed that it's more accurate. So the actual metric is recall, which means that it's not going to miss as many as what an embryologist would. So what our main focus is the efficiency, like you said. So we want to reduce that time spent searching so that you can increase the amount of sample coverage you have, because we find a lot of the problem is labs can't dedicate 3 people 6 hours each during the day to go through a sample. So if you could reduce that time, you end up covering more samples, so you can actually search through more of the prepared sample that you've got, increasing your likelihood of encountering sperm. And if you do find one sperm, say within an hour, what we normally do is we would then allocate more people so that we know that there's sperm there. It's just very, very rare, and we need to have a very fast method of searching. So this is where sperm search actually came about, where we actually needed faster searching so that you can get more sperm in a shorter period of time, so you can enable more eggs to be injected. So the efficiency is the #1 goal. Everything thereafter is the observations we're making, and that's why the primary outcome of the study is reducing time. So it is more efficient, so you get through a dish faster, which means you get through more sample faster, which increases your chances of either getting to the point where you've decided, okay, there's no sperm in the sample because we've gone through 10 dishes and we've gone through our entire prepared sample, or you get to a point where you're finding sperm at a faster rate so that you can, your logistics and your planning around your insemination is better.
So is it continuously learning what a usable sperm is? So in other words, do you have a metric? Okay, it found 10 sperm, but 5 of them were usable. And does it then, do you continue the training?
Yeah, it's supervised learning. So we facilitate the training of the model. It doesn't learn while it's being used at the clinics. It has to be done on an active basis. But the usability of the sperm is a tricky one, because if we find 5 sperm and they all look terrible, and you put them with pentoxifillin or sperm mobile, and you find that 3 of those are twitching or swimming alive, and then those will be usable because those are the only ones we have access to. So creating a metric based on morphology to grade usability is something we're not really focusing on at the moment, but we do want to focus on the twitching side, and that'll be our usability metric. But at the moment, we want it to be as broad as possible to detect anything that looks like a sperm, because it's still up to the embryologist to decide whether or not to use that sperm to inject. We just getting the embryologist to that point where they find the sperm much faster, which is the useful use case at the moment. Yeah.
Juan, would you like to?
Yeah, if we can continue, I love this topic. I think I have a couple of questions here that I would ask myself, to be honest. One of them is if this technology may work in all labs. I mean, do you need fancy equipment like, sometimes really expensive, like time lapse, or is this something that any lab could implement? And the second question is, if in the future we are moving into automation, could this sperm selection and identification and isolation could be automated somehow?
Yeah. So yeah, this is what I'll be presenting. So to answer your first question, yes, it's there's 2 things that are hardware requirements. So firstly, we do local processing. The AI processes locally, so it needs a graphics card, so like the gaming graphics card. So we've been suggesting gaming laptops that can actually handle the processing, but people can put a graphics unit in the computer that they have connected to their microscope, and a camera. So it has to be a high quality camera, and it's not like $10,000 very, very fancy cameras. It's just something that can handle a high quality image feeding straight into the AI, because the AI is using that image and it needs to have a high quality image to do those detections on. And that's it. That's how we set it up. There's a little lens adapter that kind of adjusts the field of view so that you get more field of view to basically cover more of your dish. But that's a smaller cost. So yeah, it's a plug and play. It works in labs. There's a bit of calibration that needs to be done, but fairly straightforward. And as far as the automation goes, yeah, this is our goal. Like, we want to have something that ideally, I'm sure all embryologists will agree with me, you can put the dish down and walk away, and then you come back 5 minutes later and it's done a mapping of the whole dish, and you know if there's sperm in there or not, and you can do the double witnessing or double detection and confirm all these bounding boxes were detected. these are not sperm or are sperm, next dish, or let's go and start picking the dishes up. And then over and above that, you have an automated system with robotics that can actually pick up the sperm and isolate them. But I think it gets a bit more complicated when you have very fibrous or dirty samples where a needle it takes a lot of finesse to not block a needle when you're picking up these sperm out of these very dirty tissues. So I think the human element might still be required in the isolation process, but the searching process itself is something that we can pass on to computer vision, and it can do it very well. This is kind of a low-hanging fruit that AI does very well, is these detections. They've been doing it for a long time, and they're pretty good at it.
Thank you.
The models.
That's the first step for AI to be implemented in the lab, for sure.
Yeah.
Mina, do you want to continue?
Yeah, so there's a question about processing of the specimens. Do you do any kind of enzymatic treatment, like collagenase, for example?
Yeah,
if
we
you
don't.
use it?
We don't here in Australia, but we've trained it, like I showed you those images, we've actually trained it on much more complex samples than that as well. So we've had the entire spectrum, and we also trained it on semen samples. So as far as like having a very dirty background, I always say, if you can't see it, if you had unlimited time, if you can't see the sperm, then the AI won't detect it. Like, it can't detect something that's completely occluded or not there. So we say, just try make it so that you would be comfortable searching it, and the AI can do that much faster. So as far as extra processing, labs all have their own ways of doing things, but as far as the complexity and kind of how to get sperm out of the tubules, however they prefer doing it, but we try to avoid big tissue clumps, because sperm will stick to those clumps, and we don't want that massive amount of occlusion where only a tiny bit of a tail is there, and the AI might not be as good at detecting that as well, because it's not essentially not looking like a sperm, if a half a tail or quarter of a tail, but it does still detect half tails. But we try to avoid having big clumps, but most clinics will actually also avoid that as part of their normal processing, to try to simplify the background of the dish.
Okay, Sandro is still with us, and there are a couple of questions for for Sandro. One of them is about testing. You mentioned that the criteria here are performed basically with sperm analysis, FSH, and testosterone values. Should we forget about estradiol testing in the male?
For the classification, we disregard estradiols one. This is important for the panel hormonal, assessment of the male patients. Yes, estradiol levels are important, but not for the classification. However, the clinician could use estradiol levels, especially if the patient's overweight or obese, and then we can have aromatization of testosterone to estradiol. And if we have a patient, let's say that we measure testosterone levels and we identify hypogonadism, biochemical hypogonadism, and then this patient could potentially benefit from adding aromatase inhibitors in the therapeutical regimen. So for the classification, we don't use estradiol levels, but for treatment, I think it's important to consider that. I just give you an example. So in our patients with non-obstructive azoospermia, the cohort of patients we published recently, we found that when we use it, HCG, therapy, primarily to boost intratesticular testosterone production in patients with biochemical hypogonadism and non-obstructive azoospermia, 15% of these patients actually had what we called abnormal testosterone to estradiol ratio. So we measure testosterone in nanograms per deciliter, estradiol in picomole per ml, and you make the ratio. If the ratio is below 10, it indicates that there is excessive aromatization of testosterone to estradiol. So in our study, we add aromatase inhibitors, it was anastrozole rather than letrozole, but we found that it was able to actually improve the ratio to normal again. And this was something that the clinician could consider. So the classification, we try to make it very simple with parameters that everyone can have, but obviously the clinician can add, the doctor can add more, parameters like estradiol, LH, for, during the therapeutic management to refine the treatment even further.
Thank you very much, Sandro.
Pleasure.
A couple of questions again for Dale. Do you ever leave samples where you don't find sperm overnight and check them in 24 hours? I know of some labs that do this. Have you ever done that?
Yeah, I have done that, but not with positive results. So we do it quite rarely, usually at the request of the doctor. But if we spend 6 hours searching, or we have like 6 hours combined with multiple staff and obviously including the AI, when we're fairly confident that there's nothing, we don't usually do that. But yeah, I've heard of clinics that do it, and they do fine the next day, but you're then biasing a group of patients that are not likely to have anything if you've already spent and had a lot of manpower going and searching that. But leaving samples, tubules in tissue and not processing them as well, and then searching them the next day, I've heard has some benefit, especially preserving the sperm that are there if there are sperm there. But yeah, no. Not regularly.
There is a kind of a devil's advocate question here, that asking that the samples where searching takes hours are few and far in between, even in a busy lab. So exactly how would it be applied logistically, as surely it's an expensive kit needing training, etc. How would you answer that?
Yeah. I think it's more directed at those clinics that have that big search load, patient like search load. So if you're doing 20 microTZs a year and maybe 10 of them are tough ones, this may not be really needed because it's not taking up all your clinical practice. But if we've spoken to clinics and we're actually working with clinics that have 1,000 microTZs a year, and maybe 400 of those are very, very, very long searches, and they'll have multiple searches in a day. So if you can reduce that time and at least support the clinic or support the lab in searching faster, they can either spread them out better or do more in a day, and actually the logistics becomes a bit more effective. But yeah, you're completely right. If there's very few tough searches, and we find that the clinics are different, there's hubs of severe male factor. If there's very few tough searches in a year, then this may not be needed anyway. But we do feel like, at least here in Australia, like we have to postpone a lot of these treatments. They are elective, the searches. We have to postpone a lot of them because we just can't handle the workload on our busy days. We can't handle having an egg collection where there's a time crunch and you then have to search, but you might get to the egg collection, you still haven't found sperm, it's been 3 hours. So just giving that versatility in the lab and allowing searches to be a bit faster. It's really up to what the clinic sees in the value of having something like this that reduces the time and increases the efficiency.
Yeah, well taken. Juan, do I have more questions?
I have one small and one final question for Sandro, as we're running out of time. The question is a practical question from Dr. Moises Adel from Guadalajara in Mexico. He experienced that using FSH as monotherapy, and in these patients, both LH and testosterone values went down. So he's asking if this is a common effect. And the final question that will be combined a little bit with this is, how can with these new criteria, the APHRODITE criteria, really help to frame realistic expectations about fertility outcomes? Is this a reality, or is it still something that we still need to gather data to be used as such?
So the first one, thank you very much for both questions, Juan, and who actually is participating. Thanks a lot for all the questions that came. So for FSH, we should not expect any, problem in terms of LH and testosterone. I mean, FSH will actually work on the Sertoli cells. So then we have the FSH receptors on the Sertoli cells, and basically it will stimulate, the early stages of spermatogenesis. This is not actually related to LH or testosterone. However, I just take the opportunity here to say that every time we give HCG therapy, and then yes, you get a drop in LH levels, obviously, because HCG and LH, they are very, similar molecules. HCG has a long carboxyl terminal, making it longer half-life, but they kind of work on the same LH-HCG receptor. So every time you give HCG to your patient, you should expect that the LH levels decrease. And it could be also a quality control to know that the patient's actually taking the medication correctly. And then if you give HCG, you have, a dose-dependent increase in testosterone levels. So just to clarify, but not actually, I don't see with FSH. So in terms of APHRODITE, this is just the start point for, better understanding of idiopathic male infertility. We need research, and we as a group invite, our colleagues to both explore APHRODITE criteria clinically and also in research initiatives. We need much more data. We need data actually combining therapy with lifestyle interventions, which is so important for male infertility. Changing the lifestyle, providing better nutrition, exercise, etc., which comes together with any sort of hormonal therapy that we advocate or propose. And we need to, run randomized control trials for, these different groups. We have very good evidence in APHRODITE group 1 for the gonadotropin therapy. We have randomized control trials actually on FSH therapy in group 2. And then for the other groups, we lack actually, robust evidence to, advocate the gonadotropin therapy routinely. But we propose the criteria to, move forward. We need to move forward. And this is the starting point. So yeah, I mean, we need to make collaborative efforts with different groups and then bringing, data. And I hope that we can publish in RBMO these results of these trials that you gave us the opportunity to publish APHRODITE criteria. And we hope actually many papers from different groups in the world, they choose RBMO to submit their work dealing with APHRODITE. Thanks a lot, Juan, and all editors of RBMO.
Thank you so much. Do you have any more questions, Mina?
I think we are getting to that time. Would you like to wrap up?
Yes, I will start by doing so, and first of all, thanking everyone who participated in this webinar. Thank you so much for your active participation, those of you who sent questions. More than 300 participants have been actively participating, which is a real pleasure. I want to thank, of course, my co-host, Dr. Mina Alikani, always a pleasure to share the stage with you. And of course, also the prize winners, both Professor Sandro Esteves and Dale Goss, for their great contributions. And I'm happy to have these challenging and really original papers being published in RBMO. Thank you so much.
Thank you.
Thank you so much, Juan. It's
Thank you,
been a
everybody.
pleasure as well. And in addition to echoing what Juan just said, I'd like to thank and acknowledge the hardworking team from I3, including Jacques Cohen, Peter Nash, Marianne Cervantes, Thomas Elliott, Francesco Farley, Violetta Sora, and Giles Palmer. I'd also like to thank Duncan Nicholas of RBMO for all of his efforts on behalf of the journal. RBMO will be back within I3 in September with our next journal webinar. But in the meantime, join I3 next week for another webinar with an under-the-hood look at automation in the IVF lab. The webinar will be a unique look inside the automated laboratory and the engineering leading to each automated step. We invite all of you to attend. And with that, I would like to wish everyone a pleasant and enjoyable day and say goodbye until we meet next time. Bye-bye.
Thank you. Bye, everyone. Thank you so much.